All right. The meeting will come to order. Good afternoon, and thank you all for coming to this organizational meeting of the Oversight Subcommittee for the 112th Congress. I will try and keep this meeting short so that we can begin today's hearing and accommodate the schedule of our witnesses, but also we're going to have votes called here shortly. So we're going to knock this organizational meeting out now. If we're interrupted by votes, we'll recess and come back and resume. This meeting is open to the public, and there will be an official transcript of the proceedings. And I would like to start by welcoming everyone and introducing the members who are here and announcing the members of the subcommittee. On my right, I have Mrs. Diane Black from Tennessee. The other members who are not here are Mr. Gerlach of Pennsylvania, Mr. Buchanan of Florida, Mr. Schock of Illinois, and Mrs. Jenkins of Kansas. On my left, we're honored to have the ranking member, Mr. John Lewis of Georgia. And Mr. Lewis, would you like to make some comments and introduce your members?
Well, thank you very much, Mr. Chairman. Dr. Bastani, I would like to congratulate you on becoming chair of the subcommittee on oversight. I'm looking forward to working with you in this Congress. As is in the tradition of the subcommittee, I'm sure it will continue to operate in a bipartisan fashion as we move forward. At this time, I would like to introduce the Democratic members of the subcommittee. The Democratic members are Representative Javier Becerra of California. Ron Kine of Wisconsin is not here, and Jim McDermott of the state of Washington. The gentleman from California and the gentleman from Wisconsin both serve on the subcommittee in the prior Congress. I look forward to working with them again. I'm pleased to welcome, who is not here, the distinguished gentleman from Washington, a new member of the subcommittee, Mr. McDermott, and also proud to recognize and welcome to our subcommittee the gentleman from New York, the Honorable Charles Ranger, who's a member of all of the subcommittees. Thank you, Mr. Chairman.
I thank the ranking member. And now I'd like to introduce our subcommittee staff. We have Jennifer Safavian, our staff director, Chris Armstrong, who's counsel for the subcommittee, and Lauren Savory, who's a legislative assistant. And Mr. Lewis, do you care to introduce your staff for the subcommittee?
Yes. You'll give me Karen McAfee, who's been with us for some time, and she is wonderful. She's great, and I'm glad that she's back. Thank you, Karen, and welcome.
Thank you. As the committee's rules provide, the jurisdiction of this subcommittee includes all matters within the scope of the full committee's jurisdiction. We will work to identify waste, fraud, and abuse in programs within our jurisdiction, as this hearing today demonstrates. In addition, the subcommittee will fulfill its constitutional obligation to conduct oversight of the executive branch. I expect this subcommittee to be active in this Congress and look forward to working with our minority members, majority members, to do this very important work. Mr. Lewis, do you want to make any comments about the committee agenda and your wishes?
Mr. Chairman, it's a pleasure to work with you. I look forward to continue and close working relationship during this session of the Congress.
Thank you, sir.
Thank you.
Now I'd like to recognize any members if they have any comments they want to make about the agenda. Anybody? Mr. Becerra, you're recognized.
Mr. Chairman, Dr. Bastani, just more than anything else, wanted to congratulate you on your chairmanship and very much looking forward to working with you and following your leadership as we do the work of this oversight subcommittee to try to look into every matter that falls within our jurisdiction, but I'm very much looking forward to working with you.
Thank you, sir. Mr. Rangel, do you wish to make any statement?
Yes, if we were testing bipartisanship at this subcommittee, we couldn't pick a better chairman than you. I really look forward to find the common areas that we can go, and certainly as relates to health care, to take advantage of the powers of this committee to go after those that are guilty of fraud at the expense of the lives of Americans. I can't think of a better person at this point in time to do the job than you. I look forward to working with you.
I thank you, and I look forward to working with all of you as well. Briefly on a procedural note, as in years past, the subcommittee will operate under the same rules as the full committee. The chairman and ranking member or their designee will each make an opening statement before we hear from witnesses. Other members may submit written statements for the record. The chair intends to require both witnesses and members to adhere to the 5-minute rule for testimony and questioning. If needed, we may proceed to a second round of questioning. On occasion, other members of the committee, the full committee, or other members not on the full committee may join us at the hearing, and I really look forward to working with all of you in the months ahead. With that, the organizational meeting stands adjourned. And now we will turn to today's hearing on health care fraud. I want to begin this hearing by welcoming our guests who are here to join a very important discussion about health care fraud. And gentlemen, I know you've been very busy today, and we appreciate you being here today. For our first panel, we will welcome Dr. Peter Budetti, who serves as Deputy Administrator of the Centers for Medicare and Medicaid Services and is Director of its Center for Program Integrity. Welcome. We also welcome Mr. Lewis Morris. Mr. Morris serves as the Chief Counsel to the Department of Health and Human Services Office of Inspector General, an organization that is on the front lines of the fight against health care fraud. Welcome. On our second panel, on our second panel, we'll hear from Karen Ignani from America's Health Insurance Plans and Lou Sacoccio from the National Healthcare Anti-Fraud Association. Both of these witnesses will provide insight into how the public and private sectors work together to fight healthcare fraud and where we might be able to improve anti-fraud efforts, and I thank them for coming as well. We also have a very rare chance to hear from Mr. Ike Odelugo. Through a variety of schemes involving durable medical equipment, Mr. Odelugo defrauded the Medicare program of an estimated $9 million. Since his days of committing healthcare fraud, he's assisted law enforcement efforts to track down those engaged in similar activities. Today, he will describe both how he went about defrauding the Medicare system and, in his experience, just how easy it was. This promises to be an eye-opening hearing on a very critical topic. This is not simply about those committing fraud. It's about patients and healthcare providers that are hurt by it. I come from a family line of physicians, and as a cardiothoracic surgeon, certainly understand that every dollar lost to healthcare fraud is a dollar not spent on patient care. And we're not talking about small sums of money. Healthcare spending accounts for 1/6 of our nation's economy, and within this spending is an incredible amount of money lost to fraudsters. Professor Malcolm Sparrow of the Harvard Kennedy School said before the Senate Judiciary Committee in 2009, quote, "The units of measure for losses due to healthcare fraud and abuse in this country are hundreds of billions of dollars per year. We just don't know the first digit," end quote. The FBI estimates that between 3 and 10% of all healthcare spending is fraudulent, as much as $250 billion each and every year. As much as $50 billion of this yearly fraud is in the Medicare program. And to put it another way, that's over $135 million per day in the Medicare system alone. Medicare crooks are robbing the American taxpayer each and every year of the same amount it took Bernie Madoff decades to rob from his private investors. Medicare fraud has become such an attractive target for criminals that the FBI and OAG have seen an increasing number of foreign criminal groups coming to America to exploit the program because it's less risky and a lot more lucrative than other illegal ventures. Without action, the problem is only going to get worse. The Medicare program had an estimated outlays of $509 billion in the year 2010, and that number is expected to grow at a rapid pace as 7,000 baby boomers become eligible for Medicare every single day in the year 2011. CMS expects annual Medicare spending to approach $900 billion by 2019, and as this spending goes up, so will the amount of taxpayer money potentially lost to fraud. While the Affordable Care Act included some new anti-fraud provisions, it left a lot of suggestions by the Office of Inspector General, Government Accountability Office, and members of Congress from both parties on the cutting room floor. At the same time, the law created a host of new healthcare spending programs. The Congressional Budget Office estimates these new programs will cost $940 billion over the next 10 years and much more after that. CBO has estimated the Act's anti-fraud provisions would save about $5.8 billion over the next 10 years. That's less than 1% of the expected fraud against federal health care programs during the same period. But there's also good news on the subject. Just last month, a joint effort by the Departments of Justice and Health and Human Services resulted in charges against 111 defendants for allegedly defrauding the Medicare program of over $225 million. This was the largest crackdown we've seen yet, and we look forward to hearing about these and other efforts from our witnesses. There is also a lot to explore regarding potential public-private collaborations, and as private health insurers develop new methods and technologies to prevent fraud, it's important that the public and private sectors work together in what should be a mutually beneficial collaboration. With the important reforms, new technology, better use of data, and increased cooperation between public and private sectors, my hope we can put a substantial dent in the problem of healthcare fraud. This hearing seeks to begin that process. Before I yield to our ranking member, Mr. Lewis, I ask unanimous consent that all members' written statements be included in the record, and without objection, so ordered. Mr. Lewis, we'll now turn to you for your opening statement.
Well, thank you very much, Chairman Bastani, for holding this important hearing on ways to fight healthcare fraud. This is an important topic that touches the life of millions of Americans. Our healthcare dollars are too precious, and we must ensure that those dollars are spent on health care. Last year, this subcommittee held a hearing on fraud in the Medicare program. We learned about new tools and new approaches that were being used to protect Medicare patients and return billions of dollars to the program and to taxpayers. We also explored the new provision of the Affordable Care Act that gave government agents new tools to fight fraud. Today, I look forward to learning how these tools are being used to protect the Medicare program. I'm interested in the new initiatives of the Department of Health and Human Services in this area. I'm also interested in learning how people become involved in Medicare fraud and how health plans, government agencies, and organizations can work together to detect and stop this abuse. In closing, Mr. Chairman, I would like to thank the witness for being here today. I thank you for your testimony and your willingness to share your experiences and ideas. I remain committed to protecting the Medicare program and finding new ways to work together with you and my colleagues to fight fraud in this important program. Together, we can ensure that the Medicare program remains strong for the next generation of Americans. With that, Mr. Chairman, I yield back my time.
Thank you, Mr. Lewis. We had the vote called, but I think what we'll do is take the witnesses' testimony now and then probably recess at that point for 3 votes, and then we'll return and resume the hearing. So now we'd like to turn to our first panel of witnesses. I want to welcome Dr. Peter Budetti, Deputy Administrator and Director of the Center for Program Integrity with CMS. Mr. Budetti, you may proceed.
Thank you very much, Chairman Dr. Bustani and Ranking Member Lewis and members of the subcommittee for the invitation to discuss the Centers for Medicare and Medicaid Services efforts to reduce fraud, waste, and abuse in the Medicare, Medicaid, and CHIP programs. I'm always also very pleased to be sharing the table with my distinguished colleague in fighting fraud, the Chief Counsel for the Office of the Inspector General, Lewis Morris. Mr. Chairman, from the first day that I had the privilege of accepting this job about a year ago, I've been asked 2 questions over and over again. Why do you let crooks into the Medicare and Medicaid programs, and why do you pay their claims when they're fraudulent? And I'm very pleased to be able to report to you today that we're making a great deal of progress on both fronts. We will be keeping the bad guys out of the programs, the people who don't belong there, while working to make sure that the good providers and suppliers who are our partners have, if anything, less difficulties with our processes. and we will be moving to deny claims and screen them out when they're fraudulent and should not be paid, and we actually will be doing that in collaboration with our colleagues at the Office of the Inspector General. Under the leadership of Secretary Sebelius, CMS has taken several administrative steps to better meet the emerging needs and challenges in fighting fraud and abuse. The Secretary consolidated within CMS program activities into 4 centers, one of which is a new Center for Program Integrity, and that's the one that I have the privilege of leading. This has served our purposes well. It's also helped foster our collaboration with our law enforcement partners. Affordable Care Act also enhances this organizational change by providing us with an opportunity to jointly develop Medicare and Medicaid policies together, because the new center combines the Medicaid Program Integrity Group and the Medicare Program Integrity Group under the same roof for the first time. And because the Affordable Care Act, for example, the screening provisions in the Affordable Care Act apply equally to Medicare and to Medicaid, this gives us a new opportunity to consolidate and to coordinate the programs and activities and policies across both programs to assure better consistency in what we're about. You might wonder whether administrative changes in an organization really mean anything. I can tell you that in our case, creating a Center on Program Integrity that's on a par with the other major components within the Centers for Medicare and Medicaid Services elevates the issue substantially, both internally, and also sends a message to the would-be fraudsters that we are taking this seriously. To explain how we've been transforming our fraud detection and prevention work, I now draw your attention to our chart, which I believe we've also given you some. I believe we've given you some hard copies of, this is a poster that depicts how we're moving from our historical state, which was based on pay and chase, pay claims first, and then try to find problems afterwards, to preventing fraud. That's our number 1 goal. Number 2, we are committed not to pursuing a monolithic approach, but rather to use our resources to apply to bad actors and to identify those who pose the most serious risks to our programs. Third, we're taking advantage of advances in technology and other innovations to modernize our approaches to doing this. 4, consistent with this administration's commitment to being transparent and accountable, we are developing performance measures that will specify what our targets are for improvement. 5, we are actively engaging our public and private partners from across the spectrum, because there is much to learn from others who are engaged in fighting fraud. And we know that the private sector is oftentimes victim to the same schemes and to the same fraudsters as the public sector is. Finally, we're committed to coordination and integration among all the CMS fraud-fighting programs whenever possible. I'd like to particularly stress one point, Mr. Chairman, which is that as we crack down on those who would commit fraud, we are mindful of the necessity to be fair to health care providers and suppliers who are our partners in caring for beneficiaries, and to protect beneficiary access to necessary health services. This requires striking the right balance between preventing fraud and other improper payments without impeding the delivery of critical health care services to beneficiaries. We will always respect the fact that the vast majority of health care providers and suppliers are honest people who provide critical health care services to millions of Americans every day, and we are committed to providing health care services to our beneficiaries while reducing the burden on legitimate providers, targeting fraudsters, and saving taxpayer dollars. I appreciate the opportunity to meet with you today, and I'll be happy to answer any of your questions later on. Thank you very much.
Thank you, Dr. Budetti. And I should say also that your full written statements will be made part of the record, as is customary. Now, Mr. Lewis, you may present your testimony.
Good afternoon, and thank you for the opportunity to testify about the efforts of the Office of Inspector General and our partners to combat healthcare waste, fraud, and abuse. The OIG has been fighting the fight against healthcare fraud, waste, fraud, and abuse for over 30 years. Most of our healthcare integrity efforts are funded by the Healthcare Fraud and Control Program account, or HCFAC. And this anti-fraud program is a prudent investment of taxpayer dollars. Last fiscal year, HCFAC activities returned an unprecedented $4 billion in fraudulent and misspent funds. Over the last 3 years, for every dollar spent on the program integrity and enforcement efforts, the government has returned an average of $6.80. But despite our successes, there's much more to be done. Those intent on breaking the law are becoming more sophisticated and the schemes more difficult to detect. Some fraud schemes are viral, they replicate easily, and they migrate. As law enforcement cracks down on a particular scheme, the criminals may redesign it or relocate to another city. When their schemes are detected, some perpetrators have fled with stolen Medicare funds and become fugitives. To fight healthcare fraud, our response must be swift, agile, and well-organized. My written testimony describes in more detail our collaborative efforts and fraud-fighting initiatives, and this afternoon I'd like to highlight 3 of the government's ongoing initiatives. First, our Medicare strike forces are cracking down on criminals in fraud hotspots across the country. Since their inception in 2007, strike force operations have charged almost 1,000 defendants whose fraud schemes have involved more than $2.3 billion in Medicare claims. Just last month, as you referenced, sir, strike forces engaged in the largest federal healthcare fraud takedown in history. The teams charged more than 100 defendants in 9 cities, including doctors, nurses, and healthcare company owners. The alleged fraud schemes involved more than $225 million in Medicare billings. Second, the OIG is using its exclusion authorities to bar from the federal healthcare programs those individuals who lack integrity and pose a threat to our beneficiaries. In particular, we are holding responsible the corporate executives who are accountable for their company's criminal behavior. Healthcare is not limited to career criminals and sham providers. Unfortunately, major corporations also commit fraud, sometimes on a grand scale. We are concerned that some executives of these healthcare companies may believe that as long as the ill-gotten profits outweigh civil penalties and criminal fines, healthcare fraud is worth the risk. The long and the short of it is that we aim to change that cost-benefit calculus by excluding the executives who are responsible for the fraud, either directly or because of their position of responsibility in the company. We are mindful of our obligation to exercise this authority judiciously. But if an executive knew or should have known of the criminal misconduct of his organization, we will operate on the presumption in favor of excluding in order to protect our program and its beneficiaries. Our third initiative enlists the public and the vast majority of honest healthcare providers to help prevent fraud. For example, we are conducting free compliance seminars in 6 cities. One of those is taking place in Tampa, Florida today. These seminars educate providers on fraud risks and share compliance best practices. We also recently published a fraud and abuse booklet for new physicians. It provides guidance on how physicians can comply with the fraud and abuse laws in their relationship with payers, vendors, and fellow providers. We've had over 27,000 hits on our website for this booklet alone. We're also reaching out to the public to play a very special role in helping us track down Medicare fraud fugitives. We have posted online on our website OIG's most wanted healthcare fraud fugitives. I've included a snapshot of that internet posting for your consideration. Our current most wanted list includes 10 individuals who have allegedly defrauded taxpayers more than $124 million. In conclusion, the OIG is building on our successes and employing all the oversight and enforcement tools available to us to protect our healthcare programs, the people served by them, and the American taxpayer. Thank you for your support of our mission, and I'd be pleased to answer any questions.
Thank you, Mr. Morris and Dr. Budetti. What we're going to do now, since we have this pending vote, we're going to recess, and we'll return promptly. We have 3 votes, and resume with questioning, and I appreciate your indulgence. The committee stands in recess. Committee will resume its proceedings, and we'll start off with questionings now that you all have both given your testimony. Mr. Morris, I think you were before our committee last year, and we spoke about fostering better cooperation between healthcare providers and anti-fraud efforts, and both of you alluded to this in your oral testimony. I'm interested in further exploring the role of physicians in preventing healthcare fraud, identifying it, helping you on the front end to identify it. Certainly physicians, nurses, other medical professionals are in a unique position to pick up on fraudulent activity on the ground. It's sort of, direct intelligence on the ground as to what's happening. And I know you and I spoke about the case in Lafayette, my hometown, and how it involved a whistleblower who was actually a partner of a physician who brought something to light that maybe for years had been ongoing and really was really not detectable until that whistleblower activity. So what barriers are there now that you're seeing that would inhibit physicians and other providers from coming forward and helping you in your efforts to identify potentially fraudulent activity?
I think there are a number of opportunities we have to do a better job to reach out to physicians and other professionals. Part of it is through education. I made reference in my written testimony to the roadmap for new physicians. And the idea behind that was actually spawned by medical residents who told us they didn't understand what the fraud and abuse laws were. So we put together a booklet that will help them not only protect themselves, but also be able to recognize when a practice is doing something that they might not want to get involved in. So education is part of it. I think every time we go out and demonstrate our commitment to compliance, demonstrate that we recognize that this is a complex program and that there are lots of opportunities to make mistakes, and that it's incumbent on physicians to embrace compliance, that's the way to go, that we don't, we're not a hammer looking at everything as a nail. I think building that trust goes a long way. Next week, we're meeting with the American Medical Association to get their ideas on how we can work better and ways we can spot opportunities for collaboration. So I think a big part of it is education, and a large part of it is also sending the message of compliance, that physicians and nurses and other professionals can be our partners in ensuring that waste, fraud, and abuse don't harm our program.
Thank you. Dr. Bidetti?
Yes, thank you, Mr. Chairman. We have had a series of regional fraud prevention summits, and at each one of the summits, the Attorney General and the Secretary have chaired them, and then we've had panels with law enforcement and providers and beneficiaries, and then I've put together breakout sessions with providers at each one of the regional fraud prevention summits. And I have to say, I'm extremely encouraged by the response of physicians and other providers that I've been meeting with in these groups, that they are now very interested in working with us on this, to the point where I've been so impressed that I actually have created a position within the Center for Program Integrity of a medical officer. So I'm hiring a full-time medical officer to work with the physicians and other healthcare providers around the country on program integrity issues, both to get the message to them, but also to listen and to figure out what it is that we can work on together and what we could do different inside of CMS that would be more responsive, because the message we've gotten from the providers was very straightforward, but it went in two directions. It was, on the one hand, they really want to work on this. On the other hand, they want us to do what Mr. Morris just said, which is not treat everybody the same. Recognize the big difference between fraudsters and honest physicians, and we're committed to doing that. So I think there's a real opportunity here to work very closely with the medical community and other providers, because the enthusiasm seems very strong on their side.
And if I could add one more thing,
Yeah, go
we
ahead.
share the view that physicians should be part of our team, and we also have a chief medical officer who provides valuable counsel to us as we do our work planning and ensuring that we best understand what's going on from the physician's perspective.
I know in the private sector, the private insurers often do these, go through credentialing processes. Can you talk a little bit about what you're doing now at CMS in that regard?
One of the major provisions in the recent legislation that will take effect, our final regulation will take effect on March 25th, speaks to screening of applicants to be able to bill Medicare and Medicaid. We all know that that's been kind of a soft spot in the programs, people getting in too easily. But under the new authorities, we are doing risk-based screening so that categories of providers and suppliers are assigned to different levels of risk with different levels of screening. Then they also have to revalidate periodically every 3 or 5 years, depending upon the category. So this is a new approach. It's going to mean a much greater degree of scrutiny for the high-risk providers and about the same scrutiny, but maybe done more efficiently for other providers. We get something on the average of 19,000 applications every month to become a provider in Medicare. So it's a large number of people that we have to screen through, because most of them are going to be honest, of course. But with our new screening systems, we're very pleased to have that authority, and we're putting it into place with a great deal of energy.
Thank you. Mr. Lewis, you may inquire.
Thank you very much, Mr. Chairman. Welcome. Dr. Bedetti, in your testimony, you talked about the new fraud fighting tool you have because of the Affordable Care Act. If the Affordable Care Act is repealed, what would that do to your ability to fight fraud in federal health programs?
Thank you, Mr. Lewis. Yes, the Affordable Care Act did provide us with very powerful new tools as well as resources. Both of those are extremely important to us. I mentioned the screening provisions. The Secretary also has authority to declare a moratorium on enrollment of new providers or suppliers when necessary to fight fraud. We have new tools we have a different test for when we can suspend payments when there's a credible allegation of fraud. We have coordination of a number of activities, such as termination of Medicare and Medicaid, linking those two together. There's a variety of other provisions related to enhancing the requirements for durable medical equipment and home health that are areas of high risk. There's additional penalties for violation of the statutes that are involved. There's a wide range of very important authorities in the Affordable Care Act, and we're very pleased to have them and look forward to implementing all of them.
Could you explain to members of the committee why the Medicare strike forces have been so successful, and do you plan to expand them?
Mr. Lewis, I'm very pleased with the success of the strike forces. I think I'll turn to my colleague, Mr. Morse, who's more directly involved in those.
The Medicare fraud strike forces represent a collaborative effort that include both the Inspector General's office, CMS, the Department of Justice, and U.S. Attorney's offices. So part of the reason they're successful is we're working better together. The other thing is that we're using data to spot fraud hotspots and get to the problem quicker. Instead of waiting 6 months or a year to identify an abusive provider, we know within weeks if we are finding someone who is engaged in Medicare fraud. The other thing is that by putting resources into these fraud spots and focusing prosecutors and dedicated investigative resources, we're able to more effectively deploy them in a strategic fashion. So we're getting remarkable results as a result of those efforts.
Well, thank you very much. Mr. Morris, in your testimony, you discussed the agency's ability to exclude providers from Medicare. On average, how many providers do you borrow from Medicare each year? How has your focus on corporate executive helped you fight fraud?
On average, we exclude around 3,300 individuals and entities each year from the federal health care programs. The basis of those exclusions include convictions related to Medicare fraud and patient abuse, as well as a number of discretionary authorities, loss of licensure in a state, for example. One of the things that we believe we would like to close a loophole is our ability to go after corporate executives who are responsible for corporate crime, but evade our exclusion tool by simply quitting the company. The current statute only allows us to exclude if the person continues to be employed by that sanctioned entity, and we think we need to close that loophole. We also need the ability to focus on related entities. If we identify one nursing home that has committed criminal abuse of its residents, oftentimes that's because the corporate heads have denied needed resources to that facility. it has been very difficult for us to get up to the corporate heads and hold them responsible for the abuse of residents in an individual facility. And the amendment of our discretionary exclusion authority would give us the ability to do that and be able to say to that corporate executive, you're out of our program because you're not treating our residents the way we expect you to.
Again, I want to thank the two of you for being here, and thank you for your service. I yield back, Mr. Chairman.
I thank the ranking member for his questions. The chair now recognizes Mrs. Black, if you're ready, or I can move on.
Is there someone else ask a
Yes,
question?
yeah,
If you
yeah,
would.
we'll give you some time. Ms. Jenkins, you may inquire.
Thank you, Mr. Chairman. Thank you for joining us. Mr. Bedetti, one of the new tools put in place by the new healthcare law was the requirement for face-to-face meetings for certain Medicare services. In Section 6407 of the bill, it requires that a provider conduct face-to-face meetings before certifying that a patient is eligible for those home health services. And while I understand the intent of this regulation to fight abuse of the system, I wonder if your agency has taken regional concerns into consideration. In a rural state like Kansas, we already have a shortage of physicians, and this requirement is simply not feasible for direct supervision for outpatient therapeutic services for critical access in rural hospitals. If the regulations are followed as written, many of my hospitals would have to eliminate a lot of outpatient services, thus creating access and cost issues for the beneficiary. So I was just wondering if you could speak to any discussions that you've had or any ideas for how to make this new requirement work in our rural communities.
Well, thank you, Ms. Jenkins. And I think that, of course, we're in the position of enforcing the statute as written, but we're also very much interested in not cutting off beneficiary access, and we're very sensitive to the kinds of issues that you're raising. This area of home health and also the area of durable medical equipment have been high-risk areas for us, and so it's quite important for us to move forward with implementing some of the different approaches. But that is an area that we did listen to some of the comments that we received about the timetable, and we're responding to that. And we are very interested in working on this. And I'd be delighted to listen to any specific incidents that you'd like to relate from your home state of Kansas. I'd be pleased to meet with you and listen to that and try to understand exactly what the kinds of issues are and how we might address those.
Okay, thank you. We will look forward to taking you up on that offer. On another note, CMS is expanding their use of recovery audit contractors, the RACs, an authority given to them by this new law. And I have some concerns that these contracts are for-profit and aggressively going after claims with cash-strapped hospitals, especially in rural states like Kansas. While I agree that waste and fraud needs to be found and addressed, this seems to me to be a duplication of audit services. CERT and probe audits were already occurring before this RAC process was authorized. The rate of denied claims by the RAC, which are then being overturned, is over 70%. During this time, if the hospital does not pay the recoupment requested and allows it to follow the automatic process, interest is then charged on the claim amount to the hospital at over 13%. And even if the claims are reversed, they don't get their interest back. So questions for you. What is the net cash to CMS on the RAC program? And can you speak to whether this is actually saving money in the healthcare system and increasing quality patient care, or is it simply shifting more of the cost to these small hospitals by requesting payments after the fact and adding to their administrative costs?
The Recovery Audit Contractor Program is, as you mentioned, one that's based on contingency fees, and so they're paid for out of their recoveries, and so that is the structure of the RAC program, as you mentioned. And the RAC program was implemented first in a small number of states, and it did experience a number of issues. And so the feedback that we got during the initial implementation phase has been taken into very strong consideration in shaping the way the program is being implemented going forward. We phased in the full national implementation for just that reason, and we're also taking that experience into account as we also follow the new provisions that require the expansion of RACs to Medicaid and to Parts C and D of Medicare. So the way that the RACs work is, as you mentioned, in terms of a portion of the recoveries is how they are funded. But we are working very, very hard to make sure that the kinds of things that the RACs learn both provide a basis for education to other providers so that they can deal with those kinds of issues, and also so that we understand how to improve the RAC program. I'd have to get back to you on the exact recoveries. I do know that the rate of being overturned on appeal was much higher. I don't offhand remember the exact numbers, but that it was much higher during the initial phase, the pilot phase, and that many of the issues that came up in that setting are now being taken into consideration in implementation of the full program. But I'll be happy to get you those numbers.
Okay, I'd appreciate it. Thank you.
You're welcome.
I yield back.
The gentlelady, Mrs. Black, is recognized.
Thank you, Mr. Chairman. My question is for you, Mr. Morris, and I'm going to borrow on my experiences at my state level. Tennessee was the pilot project for initiating universal care, and that program was called TennCare. It was unsuccessful, it failed, and we had to disassemble it because of its high cost. And one of the problems in that program that caused it to fail is the extreme amount of waste and fraud. And we do have an Office of Inspector General, and one of the things that we saw that was so effective is to have a hotline for people to actually call and report abuses. And it was very successful. I did notice in your testimony, and of course you have the most wanted fugitives up here and a hotline for that, but do you have something in place that if just an individual knew of someone that was abusing the program, that they would be able to make a call so that you could investigate?
Yes, we do. The number is 1-800-HHS-TIPS, T-I-P-S. We have operators standing by. They are trained to process complaints and concerns, many of which actually don't pertain to our program. As an example, we'll get calls about Social Security checks, and so the operators are trained to send those over to Social Security. But then they vet the continuing complaints and refer many of them to our Office of Investigations or our Office of Audit Services. We get thousands of hotline calls every month. And one of the jobs of these operators is to go through them, and those that have potential as a way of starting a criminal investigation or a civil investigation are sent to our investigative teams.
And to follow up on that, can you give me some kind of an idea about how effective those calls are? Are you finding that you are able to pick up fraud, waste, and abuse on those calls or from those calls?
I'd need to get back to you with the specific percentages of the universe, what actually turn into viable criminal investigations. As I mentioned, a number of them come from citizens who just need to talk to someone about a problem with the government. And so while we are not directly responsive because it's an issue outside of our agency, we do make sure they get to the right place. But I'd be glad to get back to you on the specifics of what percentage of those calls translate into a viable investigative lead.
And how is it that you let the public know that this line is accessible and available to them?
Well, it's on our website, which
Okay.
our website gets thousands and thousands of hits every week. We make a point of bringing it to the attention of communities that we speak to. I mentioned in my oral remarks that we're out in Tampa, Florida today talking about compliance training to the provider communities down there. And the hotline is one of the features that we talk to them about. So if they see a problem, they know there are avenues to bring it to our attention.
I would really like to get further feedback from you on how effective those calls are and whether you really are seeing some actual useful information. My second question along that same line is, you actually have in your written testimony that how critical it is for the Office of Inspector General to obtain real-time data on Medicare claims from CMS. Are you able to get that data in a timely fashion?
We're making important strides thanks to our partnership with Dr. Bedetti and his team. The challenge right now, frankly, is one of technology. Dr. Bedetti could speak better to this, but I believe that many of the claims processing systems that CMS has are somewhat antiquated, and there are about 20 different systems in play. CMS is making great efforts to move those systems into the 21st century so that we'll be able to get data more quickly. The other challenge, of course, we face is being able to do something with the data once it arrives at our door. And we're committing significant resources to be able to analyze the data so we can spot fraud trends and get to the site of a crime as quickly as possible.
Well, thank you. And I do absolutely agree with you, because that is one thing we found in our state is if the data was there and being able to mine that data was very, very helpful. So I certainly would encourage that we would continue to do that. Thank you. Yield back my time.
Thank you. The chair now recognizes Mr. Becerra to inquire.
Thank you, Mr. Chairman. And again, thank you very much for having this be the very first hearing that the Oversight Subcommittee does. Gentlemen, thank you very much for your patience, the interruption with votes. We appreciate your being here and the work that you're doing. Quick question. How much are you able to do with the health community in the private sector? We're talking about Medicare, for the most part, Medicaid, but we know that there's a lot going on that overlaps between the private sector healthcare system and the public sector healthcare system. Any quick examples, and I want to get to some other questions, but any quick examples of how CMS is able to work with the private sector in healthcare to try to deal with fraud that hits both public and private sector healthcare?
Sure. We're doing two things that I can speak to right off the top of my head. One is that we are now in the process of moving into, as Mr. Morris said, the 21st century with the technology and the sophisticated analytics that are currently being applied in the private sector, both in the healthcare industry and in other industries. So we're reaching out to get the best ideas and the best approaches from the private sector and use them in the public programs. That's one thing that we're doing. We're also have been engaged for some time in a dialogue with the private sector about building a public-private partnership to work together to fight fraud, and that's something that my colleague from the Inspector General can also speak to.
I did a quick check last night of the number of cases that our Office of Investigations is working with its private sector counterpart. We have 50 ongoing cases where we're sharing intel, resources to tackle a problem which is both on the private and the public side. The NHCAA, and you'll be hearing from its representative in the next panel, I think will tell you that we are working very effectively together and finding new ways to find ways to improve. We're working on a best practices document, for example, so that we can find additional ways to multiply our efforts.
Excellent. Well, I hope you continue to give us reports on how you're working together, because we know that the costs of health care outside of Medicare and Medicaid are helping drive the costs of Medicare and Medicaid higher. And so to the degree that we help them tamp down costs on the private side, it helps us control them on the public side. A question, and I had asked my staff what the acronym stood for, because last year my father ended up having a difficult time, and he survived an episode with a heart condition, but he got a CPAP machine, and it stands for Continuous Positive Airway Pressures. I got to the point of just calling it the CPAP, the air machine. It helped him breathe. We know that there has been an issue with fraud in the area of DME, durable medical equipment. The CPAP machine, the oxygen equipment, the wheelchairs, the hospital beds that are often provided to beneficiaries under Medicare. And in the next panel, we're going to hear from an individual who was convicted of Medicare fraud involving durable medical equipment. I wonder if you could tell me what was done in the historic health care reform, the Affordable Care Act, which is going to help us address what we know is pretty aggressive fraud in the area of durable medical equipment.
The area of durable medical equipment, as you mentioned, also is in fact one of the high priority areas. And I mentioned before that we had structured, as the Act requires, our screening processes by category, and the highest level of risk includes new durable medical equipment suppliers, and so they will be subject to the highest level of screening. For new entrants, there's also provisions in the Affordable Care Act that provide for increased surety bonds and other kinds of oversight of new DME providers and initial claims. We're also very much involved in a completely different approach, which has to do with the implementation of competitive bidding for durable medical equipment, because when you have a limited number of bidders who undergo scrutiny to get into that program, we believe that will also be helpful in terms of having controls on it. And we've had a series of durable medical equipment specific initiatives in the past in South Florida and elsewhere. So it is something that we're attacking from multiple points, because that's an area that we have to do a better job of preventing.
Mr. Morrison, instead of answering to that question, I know I'm going to run out of time. Can I ask one last question? You obviously are using personnel. They're obviously having success in helping us detect and track down some of this fraud. What happens if you have to furlough or reduce your personnel because of budget constraints?
Because a significant part of our funding is off of the general appropriations, is through the HICVAC account, we are going to be able to keep a law enforcement presence. It will be reduced, unfortunately. I think the other challenge we'll face will be just the general disruption that comes when the government goes through a shutdown process. We'll spend a lot of time on that instead of catching bad guys. But to the extent possible, with the funds available, we'll continue to fight against fraud.
Thank you. Thank you, Mr. Chairman.
Thank you. Mr. Gerlach, you may inquire.
Thank you, Mr. Chairman. Thank you, gentlemen. Really quickly, want to give you a constituent matter that I just uncovered 2 months ago, and I'd like to get your reaction to it based upon your testimony that you've presented to the subcommittee. About 2 months ago, a constituent of mine, someone who's on Medicare, sought medical advice from his orthopedic surgeon regarding an MCL problem he was having with his knee. The orthopedic surgeon then prescribed a knee brace for him to help him with his recovery of that situation. When Medicare was billed for that knee brace, it was billed for about $690. That really struck this gentleman as being very odd based upon the knee brace that he got. So he went online to the manufacturer's website and saw online that the manufacturer is only retailing this knee brace for about $190, about 2.5 to 3 times more being reimbursed by Medicare for what the manufacturer is retailing this knee brace for. So with that as a background, Mr. Bedetti, for example, in your testimony, you indicate that the Affordable Care Act has offered more opportunities and more provisions to combat fraud, as well as new tools for deterring wasteful and fiscally abusive practices to ensure the integrity of the program. So what would your specific recommendation be today to immediately halt this practice of Medicare paying 2.5 to 3 times for this kind of medical product? And I'm sure there's thousands of medical products that the system or the program reimburses for that are probably out of whack of what you could pick it up retail for. What are you doing specifically to halt that practice immediately?
Thank you. Thank you for that question, Mr. Gerlach. What I mentioned just a minute ago, the competitive bidding for durable medical equipment projects a very substantial reduction in the prices that will be paid by Medicare. I believe it's on the order of 32% based upon competitive bidding. And we believe that introducing this level of competition into the provision of durable medical equipment supplies is an important step towards combating exactly what you just mentioned. I would also add, in follow-up to Ms. Black's question from a minute ago.
May I interrupt just so I
sure.
understand exactly what you're saying?
Okay, sure.
So you're going to have folks competitively bid to have the ability to be the entity that provides the product for that particular medical condition. Are you going to relate at all whatever those bids are to the real-world retail price for those products? Or are you just going to allow bidding among certain entities, but they're still, even though you pick the lowest bid, may not be tied to what the reality is in terms of what that product retails for in the real world?
You know, I'd be very, I can't speak to the exact market dynamics that governed our initial implementation of the competitive bidding, Mr. Gerlach. I'd be happy to look at exactly that issue for you and get back to you on how well the bids that we took compared to the market prices that we otherwise would have seen, because that is the core of what we're trying to do, is to get to a point where we're paying either market price or whatever the market should be charging for things.
When was the last time, if you know, this competitive bidding process was used for a knee-brace product in the program, so that would have been the basis to set this knee-brace price at $690?
We're just implementing the competitive bidding this year, and it was in 9 areas, but the projection is for it to be phased in across the country. And I'll be happy to get you all the details if you'd like.
Thank you, sir. And real quickly, Mr. Morris, your office obviously is responsible for auditing and evaluating these programs. Have you, at any time in the past, looked at the overcharging, overpayment for products of this nature? And if so, what have your recommendations been, and how has CMS handled those recommendations? Or has this been an issue you've not looked at before?
This is an issue we've looked at a great deal over the last 10 years or more. The OIG, of course, does not set prices. It merely does the audits.
Right.
But we've looked at everything from wheelchairs to oxygen concentrators to orthotics, and in each case reported back to CMS that we believe that the program is paying way too much.
And what has been the response by CMS to those recommendations?
It has varied a great deal on the particular product, but CMS has generally been receptive to our recommendations. In some instances, they've put it out, they felt they had legal barriers to actually reducing the prices. The competitive bidding process.
Have you had a systematic recommendation to cover all of products that are utilized through the program, or have your recommendations been product-specific, a wheelchair or a knee brace or an oxygen tank?
They've been product-specific, but with broader programmatic recommendations that would go to the principle of we ought to pay at market rate and not above it.
Yeah, it seems to me there ought to be some systematic recommendations, not individual equipment-specific recommendations. There's probably problems across the entire spectrum of product reimbursement in the program. So appreciate your additional thoughts on that. Thank you, Chairman.
Mr. Kine, you may inquire.
Great. Thank you, Mr. Chairman, and thank you for holding what I think is a very important hearing, and hopefully we'll have an opportunity in the course of this session of Congress to get into this as well. I think it's very helpful. Nothing drives people crazier than the thought of wasteful payments going out, the fraudulent claims being made against the Medicare system. So we appreciate the work that both of you gentlemen and your agencies are doing to combat this. Mr. Morris, let me start with you. Have you had a chance to quantify the type of return we get on the dollar that we spend on anti-fraud measures? What type of return that we're recovering from that?
Yes, we have. We're very mindful of how valuable the taxpayers' dollars, and we want to make sure we're a good investment. If you look at the money spent on our health care anti-fraud efforts over the last 3 years, we brought back to the government $6.80. That's a great ROI. So the short answer is yes, and it's a great number.
So under the Affordable Care Act, if I got my numbers right, roughly $350 million was authorized over a 10-year period for the feet on the street efforts. And I think the President's 012 proposal was asking for about $270 million for HICFAC. Do you think that's going to be a wise use of the money as far as the potential for return?
I confess that I have a somewhat self-interested answer here. Yes, of course. But I think more seriously, I can tell you that there are cases that we want to get to that our current resources do not allow us to. By way of example, we've put a lot of resources into the Medicare fraud strike forces and realized a tremendous return both on taking bad guys off the street and saving Medicare money. But it has meant that some of our civil cases involving pharmaceutical fraud and others, have had to wait. The ability to bring more feet to the job and focus on those cases, I think, will return very positive benefits.
Yeah, so you don't have to answer this, but it just seems intuitively then that this is an area where further budget cuts may end up costing us more in the long run if we're taking away that enforcement capability or investigative capability. Now, to follow up on what I think Ms. Black was referring to earlier, are we getting better at being able to distinguish innocent errors that are submitted versus outright fraudulent practices? Mr. Budetti?
This is a very high priority for us. to do exactly that, and that's why I mentioned the risk-based approach that we're taking. We are implementing a variety of different private sector approaches to analyzing data, and not just claims data, but moving into a much wider range of data. We've set a goal of having essentially 0 false positives. We want to be very sure that that we have reached the right conclusions in analyzing the data. So yes, so I believe that that we're making great progress in that direction.
Well, let me ask you, both of you, if you have an opinion on this, but I think ultimately the key to whether healthcare reform is successful or not is our ability to change the way we pay for healthcare in this country, starting with Medicare, and moving from the fee-for-service system we currently have under Medicare to a fee-for-value, or a quality or outcome-based reimbursement system. If we're successful in making that transition to a new reimbursement rewarding value over volume, what impact is that going to have on fraudulent practices throughout the country?
I think it's going to have the potential of reducing fraud in the conventional paying a kickback to get a service ordered. The challenge we will face is that in any system of reimbursement, there are going to be opportunities to exploit it. And so as we move into an integrated delivery system where we're rewarding quality, we're going to also need to make sure that some of the other perverse incentives don't result in skimping of care, steering of patients, and we're mindful of those risks. But I think it is so critical that we move to an integrated system that we're going to have to give the system an opportunity to sort of try itself out. But every system has opportunities for exploitation, and we're going to need to be vigilant.
Sure. Dr. Bedetti?
Yes, I think that, as you're well aware, we are moving towards implementing a number of new ways of organizing and paying for care with accountable care organizations and medical or health homes, value-based purchasing, variety of different initiatives. In each case, we are raising exactly what Mr. Morris raised, which is, if we're going to approach this from a new direction, let's look at what the vulnerabilities are. Let's do that prospectively so that we don't set ourselves up for a different kind of problem going forward. So yes, we might very well escape some of the past problems that we've had. We want to also be on the lookout for what kind of new situations we might encounter as we change the system.
Great. Thank you both. Thank you, Mr. Chairman.
Mr. Buchanan, you may inquire.
Thank you, Mr. Chairman, for holding this important hearing. Gentlemen, I was curious because I hear so many different numbers, and I'm a member from Florida. But when you look at just the fraud or abuse or whatever for Medicare and Medicaid, what is the best number? What's the range that you use? Because there's so many numbers out there. I hear 100 billion, 60 billion. What is your estimate as it relates to, basically Medicare and Medicaid?
Well, I think we share your frustration that there is not one number, and there seem to be all over the place. You hear everything from 3 to 10%, 3% being what the NHCAA estimates, 10% being what the GAO estimated about 10 years ago. To be honest with you, I don't think we know with precision how much fraud there is out there. That's in part because by the nature of the crime, it's concealment. Good frauds go undetected.
But what's your best estimate? I mean, what if you someone deals in this every day, what would you say is a range from a high to a low or whatever? Or
My best estimate, not based on any empirical proof, but just everything we see, is that the fraud ranges anywhere from about $60 to $100 billion a year across all systems, private and public.
And how much is the public system, Medicare, Medicaid, just your estimate? I know it's not, I'm not holding you to it, I'm just trying to get a sense of what that might be.
Well, if we assume that it's both public and private are preyed on by the same set of criminals, I think we'd presume that we would share our proportion of the total health care expenditures. So it's going to be in the tens or billions of dollars. It's way too high.
Doctor, do you have your thought on it?
Yes, sir. I think that whatever it is, it's too high. I think that whether we have a number or not, that one thing that we do see is that the more we look for it, the more we find. Mr. Morris mentioned the return on investment. The return on investment has been going up consistently over time, as we've spent more money to fight fraud. I view that as both good news and bad news. It means that it's a wise investment of public funds. It also means that there's still we're not on the flat of the curve, so to speak, that there's still quite a bit of fraud out there for us to find and to deal with. So I think that whatever the number is, it's very substantial, and it needs our attention.
Yeah, let me mention, you always hear, and you brought it up here a few minutes ago, about South Florida, Miami, Dade, Broward counties, and being the only member of Ways and Means in Florida. I hear a lot of that even in my own district. But let me state something that I read. It was reported by University of Miami. There was a recent report out that said it's their understanding that 6 of the nation's top most wanted Medicare fraud victims have been given refuge in Cuba. Could this be the case? Is it ongoing? Is there any organized crime component that you're aware of as it relates to fraud, and can it be any kind of a tie-in to the Cuban government?
I'm not aware of any tie-in to foreign governments as it relates to the healthcare fraud perpetrators that we either have listed here or elsewhere.
Have you heard about the 6 of the nation's most wanted Medicare fraud victims are in Florida? I mean, are in Cuba?
I have not. I have heard rumors that 3 of them are in Cuba in a Cuban jail.
Okay. Okay, well, we hear different information. Doctor, do you have anything to add to that?
No, I don't.
Okay, so the other thought is that, and you touched on this a little bit earlier, that you are working with the private sector together to combat fraud. In terms of the various agencies, you know, and I heard you touch on it a little bit. Could you expand on that a little bit more, what you're doing? I know you can't be everywhere at all times, but in terms of working with the private sector to deal with fraud, what are you actually doing?
Well, let me give you a great example. The Investigation of the Year awarded by the NHCA last year was for a collaborative effort in Kansas focusing on a pill mill. 2 defendants who were pushing painkillers. They were associated with potentially 60 deaths from drug overdoses, and the DEA, FBI, our teams, and a number of private insurers came together, pooled their information on the prescription patterns and practices, identified the trends, and were able to focus down and build a case that would have otherwise taken far longer and far more resources. The result is we got the convictions, and we were able to close down a pill mill that was threatening citizens' lives. That's a great example of how we can work with the private sector to pool our resources and our intel to get to a just result.
We have 1,300 pill mills. We're dealing with that right now, but I'll yield back.
Thank you. Gentlemen, thank you for your testimony and your answers to these questions. Please be advised that members may have written questions they would like to submit, and would ask you to oblige. And thank you for the work you're doing, and we look forward to hearing from you again on this ongoing problem that we're having to deal with, Medicare.
Thank you very much.
Thank you very much, Mr. Chairman.
Thank you.
Members.
We'll now begin our second panel, and I'd ask the second panel to take their seats. All right. I want to thank and welcome Karen Ignani, President and CEO of America's Health Insurance Plans, Mr. Louis Sacoccio, Executive Director of the National Healthcare Anti-Fraud Association, and Mr. Ike Odelugo, who has pled guilty to state and federal charges related to Medicare fraud. I want to thank all of you for being here as we try to delve into this important subject and try to understand what more might need to be done. You'll each have 5 minutes to present your oral testimony. Your full written statements will be made part of the record. And Ms. Ignani, we'll begin with you. Thank you.
Thank you, Mr. Chairman, Dr. Bustani, Ranking Member Lewis, and members of the subcommittee. We are pleased to have the opportunity today to discuss how health plans are playing a leadership role in fighting and preventing healthcare fraud, how we are working with the Department of Health and Human Services, a number of you inquired about that, how we are working with law enforcement, and where there are opportunities to do even more. Our members have developed cutting-edge techniques, as you've heard this afternoon, to identify fraud and halt practices that lead to substandard care. We are involved in flagging the delivery of inappropriate or unnecessary services that may harm patients, inappropriate charges or charges for phantom services, detecting unlicensed or unqualified personnel, and identifying substance abuse and increasingly identity theft. Our members' anti-fraud initiatives have prioritized preventing fraud before it takes place rather than paying and chasing after the fact. We're proud that these initiatives were models for the important new efforts being made in the public sector and believe even now more progress can be made. Health plans fight fraud by operating special investigations units that are staffed with personnel with clinical, statistical, and law enforcement expertise. They do 4 things. They perform intensive license and qualification review. That's the credentialing function. They work to identify potential fraud before a claim is paid by employing sophisticated software techniques to detect anomalies in billing. They investigate the clinical basis for the claim that has been flagged and tagged by relying on physicians, pharmacists, and other trained personnel. Quite a number of these matters, as you heard this afternoon, involve medical equipment, infusion, and narcotics prescribing. We take action by suspending payments when fraud is detected, jettisoning providers from networks, and providing information to law enforcement. Increasingly, efforts are focused on preventing identity theft. When a patient borrows a friend's identity to obtain insurance coverage, harm can result to the real beneficiary of that insurance policy who may be inappropriately or incorrectly tagged with the wrong blood type or identified inappropriately as having a condition they do not have. We detect substance abuse as a very, very high priority activity, a current fraud and abuse initiative that literally has life and death significance. Looking ahead, we've offered the committee this afternoon 4 recommendations. First, we're urging a reconsideration of how fraud prevention and credentialing programs are treated under the interim final regulation for the new medical loss ratio requirement. The Department of Health and Human Services interim final rule adopts the recommendations that were made by the National Association of Insurance Commissioners, which only in those recommendations allowed fraud recoveries to be considered as quality improvement, not the cost of programs that would have been the focus of discussion this afternoon, the prevention and early intervention. This is at odds with the promising efforts now being incorporated into the public sector programs, which are based on the very programs that our members have pioneered. Similarly, the MLR-IFR interim final regulation excludes provider credentialing from the definition of activities that improve healthcare quality, which is now recognized as a critical function, and we applaud the department for doing that and the efforts that are underway. We urge the committee to ask for reconsideration of how these programs are handled. Second, we have recommended that existing partnerships between the private and public sector be strengthened. We've made a recommendation about how that can happen. We think a simple aspect of more clarity about the ability of law enforcement to share information is important in this endeavor. Third, we recommend that the health plans should be included in restitution agreements when the Department of Justice or other enforcement agencies enter into agreements and obtain restitution from people who commit healthcare fraud. This is done sometimes, not always, and we think there are opportunities here. Fourth, we recommend creating a safe harbor for health plans that supply information concerning suspected healthcare fraud to any public or private entity. Mr. Chairman, there's been a great deal of progress made in certain states. We're encouraged by that. We think there should be a more uniform approach, and we hope that the committee might consider that and more attention could be made to that matter. This concludes our testimony. We appreciate the opportunity to be here. And, Mr. Chairman, we're very happy to have the opportunity to sit next to Mr. Sicoccio, who has done a fantastic job operating his group that has brought many in the public and private sector together to share this kind of information. Thank you very much.
I thank you. Mr. Sicoccio, you may proceed.
Thank you. Good afternoon. Chairman Bastani, Ranking Member Lewis, and other distinguished members of the subcommittee. I am Louis Sicoccio, Executive Director of the National Healthcare and Fraud Association, NHCAA. NHCAA was established in 1985 and is the leading national organization focused exclusively on combating healthcare fraud. We are uncommon among associations in that we are a private-public partnership. Our members comprise more than 85 of the nation's most prominent private health insurers, along with more than 80 federal, state, and local government law enforcement and regulatory agencies that have jurisdiction over healthcare fraud, who participate in NHCAA as law enforcement liaisons. NHCAA's mission is simple: to protect and serve the public interest by increasing awareness and improving the detection, investigation, civil and criminal prosecution, and prevention of healthcare fraud. The magnitude of this mission remains the same regardless of whether the patient has healthcare coverage as an individual or through an employer, or through Medicare, Medicaid, TRICARE, or other federal or state program. Healthcare fraud is a serious and costly problem that affects every patient and every taxpayer in America. Just as importantly, healthcare fraud is a crime that directly affects the quality of healthcare. Patients are physically and emotionally harmed by healthcare fraud. As a result, fighting healthcare fraud is not only a financial necessity, it is a patient safety imperative. Also, healthcare fraud does not discriminate between types of medical coverage. The same schemes used to defraud Medicare migrate over to private insurers, and schemes perpetrated against private insurers make their way into government programs. Additionally, many private insurers are Medicare Part C and D contractors or provide Medicaid coverage in the states, making clear the intrinsic connection between private and public interests. As a result, the main point I want to emphasize is the importance of anti-fraud information sharing between private and public payers. NHCAA has stood as an example of the power of a private-public partnership against healthcare fraud since its founding, and we believe that healthcare fraud should be addressed with private-public solutions. One salient example that illustrates the power of cooperative efforts against healthcare fraud can be found in South Florida. In response to the challenge of healthcare fraud schemes in South Florida, including fraud schemes involving infusion therapy and home health care, NHCAA formed the South Florida Work Group. In meetings held in 2009 and 2010, this NHCAA work group brought together representatives of private insurers, FBI headquarters and field divisions, CMS, HHS OIG, DOJ, the Miami U.S. Attorney's Office, and other federal and state law enforcement agencies to address the healthcare fraud schemes emanating in South Florida. The details of the emerging schemes, investigatory tactics, and the results of recent prosecutions were discussed with the dual goals of preventing additional losses in South Florida and preventing the schemes from spreading and taking hold in other parts of the country. This type of anti-fraud information sharing is critical to the success of anti-fraud efforts. HHS OIG, CMS, and DOJ have demonstrated a strong commitment to information sharing with private insurers and are working with NHCAA to identify the barriers, both actual and perceived, to effective anti-fraud information sharing with the goal of increasing the effectiveness of this critical tool in the fight against healthcare fraud. It would greatly enhance the fight against healthcare fraud if federal and state agencies clearly communicate to their agents the guidelines for sharing information with private insurers, emphasizing that information sharing for the purposes of preventing, detecting, and investigating healthcare fraud is authorized and encouraged, consistent with applicable legal principles. In addition to information sharing, the other effective way to detect emerging fraud patterns and schemes in a timely manner is to apply cutting-edge technology to the data to detect risks and emerging fraud trends. The pay-and-chase model of combating healthcare fraud, while necessary in certain cases, is no longer tenable as the primary method of fighting this crime. In recognition of this fact, many private sector health insurers now devote additional resources to predictive modeling technology and real-time analytics, applying them to fraud prevention efforts on the front end prior to medical claims being paid. The federal government has also recognized the value of real-time data analysis as a key aspect of its interagency HEAT initiative. The Medicare Strike Force model, as you've heard, employed by the HEAT program, combines Medicare paid claims into a single searchable database, identifying potential fraud more quickly and effectively. Additionally, CMS is working to implement risk scoring technology to apply effective predictive models to Medicare. NHCA is encouraged by the renewed federal emphasis given to fighting healthcare fraud, and NHCA knows continued investment and innovation are critical, and as greater attention is given to eradicating fraud for our government healthcare programs, we urge decision makers to also recognize and encourage the important role that private insurers play in keeping our healthcare system healthy and free from fraud. Thank you for allowing me to testify today, and I certainly would be happy to answer any questions. Thank you.
Thank you, Mr. Sacoccio. And Mr. Odeluga, thank you for being here, and you may proceed, sir.
Thank you, Mr. Chairman and members of the committee. It is with profound humility and deep gratitude for this opportunity that I come before the members of the committee today to provide testimony on the pressing issue of Medicare fraud in the durable medical equipment sector of the healthcare services industry. My name is Haribuna Ike Odelugo. I am from Nigeria and came to the United States in 1998 with the sincerest of intentions to eventually acquire my master's degree. Instead, beginning in 2005 and extending to 2008, I engaged in a business that presents unique opportunities for fraud and abuse. And speaking of the DME sector of the healthcare services industry, I engaged in fraud and abuse in this industry. I participated with others in 14 different companies, reaching 11 different states. DME fraud is incredibly easy to commit. The primary skill required to do it successfully is knowledge of basic data entry on a computer. Additionally required is the presence of so-called marketers who recruit patients and often falsify patient data and prescription data. With these two essential ingredients, one possesses a recipe for fraud and abuse. The oven in which this recipe is prepared is Medicare system. This system has a number of weaknesses which are easily exploitable. This is a non-violent crime and is often committed by very educated people, including business people, hospitals, doctors, and administrators. It reaches across all ethnic and racial lines. It relies on an often unsuspecting victim base of Medicare recipients, elderly citizens who long for attention and care, who simply want someone to talk to. It also at times involves patients who willingly participate in the fraud. DME providers who engage in this type of fraud either do their own billing or outsource the billing to persons such as myself. In my own experience, I dealt with 14 DME companies and did their billing. I often dealt directly with the marketers who provided patients referrals, most of them fraudulent. I also dealt with physicians who knowingly participated in this fraud by knowingly writing prescriptions when they knew they were not medically necessary, or at times writing prescriptions for patients they never saw. I am not here today to appear proud of what I have done, yet I want the members of the committee to understand that I have done everything humanly possible to correct my past wrongs. The opportunity to testify today before this subcommittee is something I am very grateful to be able to do. Mr. Chairman and members of the committee, I want to thank you for allowing me the opportunity to address the subcommittee on oversight. I sincerely regret my actions over the past years, and today's testimony, I hope, will be understood as part of a continuing effort on my part to help in any way I can to correct my wrongs and prevent future wrongs. I also wish to take this opportunity to publicly thank Assistant United States Attorney Al Barboni and Special Agent Joseph Martin of Health and Human Services for the confidence they have placed in me during the course of my continuing cooperation. Finally, I wish to publicly apologize to this body and most of all the American taxpayers. I am now prepared to answer any questions from the members of the committee. Thank you.
Thank you, Mr. Odeluga. We appreciate your testimony. Ms. Ignani, in your testimony, you mentioned the possible negative impact of the medical loss ratio rules on a private insurer's anti-fraud efforts. Could you elaborate more on that? What will happen if this rule is fully implemented, and what the impact will be on your efforts to, or your private insurer companies, their efforts to conduct anti-fraud activities?
Thank you, Mr. Chairman. We appreciate the opportunity to speak more about this. Essentially, what the MLR requirements involve in a direct way is that it allows plans to categorize expenditures for healthcare quality activities. What is not included in the quality activities are two buckets, basically. Number one, credentialing of providers. Dr. Berdetti talked very effectively about the importance of that being added to government programs. We agree with that we've pioneered those techniques. We're not allowed to account for those under quality in the present recommendation that was submitted by the NAIC to the Department of Health and Human Services. Number one. Number two, also the preventive aspects that I talked about and Mr. Sicoccio talked about, the data mining, the predictive modeling, the early detection, prevention, that now the department is working very hard also to incorporate into their public programs. Again, important activities underway at HHS. We've had those activities underway for very, very many years and have been very successfully undergoing and engaging in programs and efforts. So we flagged that both for the NAIC, we flagged it for the department, and we wanted to flag it today as the committee is focusing on the progress that's being made now in public programs, particularly incorporating these very techniques. It's penny wise and pound foolish, essentially.
And so in addition to that, both you and the panel before you talked about the importance of public-private partnerships.
Yes, sir.
And if this rule goes forward, it really hurts your ability to conduct anti-fraud activity at a time when we're trying to enhance and move forward on these collaborations between the private sector and the public sector. Is that
The incentives are, as you have correctly stated, now under the recommendations that were made originally by the NAIC, and there was considerable discussion about that here, it's only for the pay and chase situation. And that's precisely what everyone wants to get away from, and what our plans have worked very, very hard to actually not only think about executing programs, but actually operating programs very effectively and very successfully. And as you heard from the Mr. Morris, who spoke very effectively about this as well, we are now turned to by law enforcement agencies for help in their activities and very effectively doing that.
Mr. Sicoccio, do you want to comment on that as well?
Yes, we feel that if you look at the federal side, a lot of resources have been put into anti-fraud efforts. And the President's budget, I know, asked for an increase of discretionary funding for the Healthcare Fraud and Abuse Control Program. There are additional fundings in the Affordable Care Act. It doesn't make sense to put all those investments on the federal side and then create a rule that's really a disincentive for private plans to invest in the type of preventive type techniques that you want to use to go after fraud. And
runs counter to the whole effort, it seems.
That's correct.
Okay. Thank you. With regard to the interaction between private sector and public, when a private insurance company highly suspects fraud or actually detects fraud, you do contact CMS to notify them, right? Most of the time or all the time?
The first place that normally this contact is made is law enforcement. Oftentimes there are criminal cases that our plans suggest and expect based on what they're seeing in their data. So oftentimes that's the first place. Increasingly, Mr. Chairman, there will be this exchange of information now with the new activities that are being built in the public sector, where you have similar kinds of activities, so it's either easier to go back and forth. And there has been a great deal of communication, both in Mr. Sicoccio's association as well as with law enforcement directly. We think there's an opportunity for more opportunity for information sharing from law enforcement to the private sector when there is a case that has been opened to more routinely share information. And we think that there needs to be some clarification in that regard to make sure that agents are aware that that is permissible and they can do that.
So you're still encountering some barriers there whereby a federal agent may not feel comfortable cooperating or collaborating with?
In some cases, we think there's just an opportunity for clarity here.
Okay.
And there could be more consistency and more uniformity of practice.
And if you have further suggestions specifically on how we might do that, you might bring it forward to the committee.
Thank you, sir.
Thank you. Mr. Kine, you may inquire.
Thank you, Mr. Chairman, and thank the panelists for your testimony here today. Karen, let me just continue with you for a second. Mm-hmm. You said first referral goes to local law enforcement for follow-up and possible prosecution. Have you found that they have the level of competency or expertise in order to pursue these investigations? And
It's a very good question that you're posing, and it really depends on the issue at hand. This is a very important question. In the case of very active, we had a case recently where one of our special fraud investigative units found that they were being billed by infusion clinics that weren't providing, it was phantom procedure. They weren't providing services to anyone, we were just being billed. And they noticed that in the data because they noticed an uptick from what was going on usually in the community, so it caused them to ask questions and so on. That's fairly straightforward in terms of how that compares statistically with norms. If you have certain overutilization of procedures which are very clinical, very high tech, we have found now that there is a great deal of activity going on in law enforcement to make sure that they are getting the kind of medical expertise that Mr. Morris talked about, frankly, with the medical director being involved in the OIG activities. There's quite a lot of that going on. And I know Mr. Sicoccio has far more experience than I do, so I'm happy to yield to him, Mr. Kine, for more explanation about this. But generally, we're finding that in our units, we have staffed them with people who know about law enforcement, people who are clinicians, people who know about pharmacy, and people who are statisticians. And that's served our plans very, very well to have a full panel of techniques they can deploy.
Mr. Sicoccio, do you have anything to add?
Mr. Khan, one of our goals and one of our missions at NHCAA is to educate investigators about fraud. So we probably educate between 150 and 200 FBI agents every year, about 50 to 70 IG agents every year. So that's an important part of what we do too, and that was the concept behind this private-public partnership. And when this education takes place, it's both private and public investigators coming together, sharing their experiences, sharing what they know, their best practices. And that's really critical. So I think we're seeing that, for example, the FBI and the IG does have that expertise. As they bring in new agents, we take them to our programs, educate them about what they need to know, because you're dealing with coding and medical jargon and those kinds of things that, you know, say a new FBI agent maybe isn't aware of. But I know the agency is very good about getting their agents trained, and we do a lot of that with them.
Yep. And Karen, if we eventually move from fee-for-service to fee-for-value reimbursement, is that going to have any type of impact on anti-fraud measures?
You know, this is also a thoughtful question. I heard it that you posed it to the last panel, and I think yes, but. Let me just tell you the but I was thinking when I was sitting back there listening. What we have seen in some of our fraud units also is when you go to bundling of payments and you have more integration, there are new skills that are required to make sure that we're not seeing upcoding in that situation. So yes, but I want to provisionally say that there are new skills that we're already in tools deploying to make sure that we can spotlight problems. Also, moving from the ICD-9 to ICD-10 coding system, you're going to be creating thousands of new codes. We are very concerned about upcoding there as well. So we're going to be deploying new skills to make sure we're spotlighting that early. So.
And what about the build-out on the HIT systems and the integration of those systems?
Well,
is that going to enhance data collection?
And it has in our case. It's really, what we have seen is the investment that we have made in infrastructure and HIT has really allowed the statistical tools to be deployed. They're very sophisticated, and you need the right kinds of personnel to operate them, obviously, but this investment in IT allows that to move much faster. In the old days, we used to be looking at clinical charts. Now we're looking at data, and we can look at reports, and we look at statistical profiles, frankly, of areas and different practitioners.
All right, thank you.
Thank you.
Got to run and vote.
Let me follow up on some of the points you made in your testimony. And you see members moving off of the dais here because we had a vote series called about 15 minutes ago. And so that's why they're running over to the floor and voting, and some of them are coming back as well, given the space that we have between a couple of the votes. So we'd like to try to conclude the hearing today, and hopefully we can do that with your continued testimony here over the next few minutes. Mr. Odeluga, if I may go to you, sir. Thank you for testifying today, and thank you for your insights. And we heard from the other two presenters on the panel with you some of their more systematic views of what's happening with healthcare fraud, their experiences out there in the in the system from a systematic standpoint. You were very much involved in fraudulent activity through your individual activity and those you partnered with. You said in your testimony that it was incredibly easy to commit fraud, and as a result, you built a system for over $1 million, if our information is correct. Is that accurate? How long did it take you to put in place the plan of action that you engaged in, getting other folks to participate with you, to the point where you're able to make claims and ultimately collect over $1 million in Medicare reimbursement payments?
It didn't take me that long. It was just a matter of understanding the system and just.
Okay. I'm sorry, say again?
I said it didn't take that long. It was a matter of understanding the system and setting up the structures.
Okay.
Not more than a month.
Okay. The people you worked with in this process, in this scheme, how did you approach them, and how willing were they to participate? Because obviously they were going to make money out of this scheme that they shouldn't have been making.
Yeah.
Was it pure greed, or what was it that got you to entice them to participate in this fraudulent activity?
Basically, I didn't approach them. I found a loop in the system where I could bill for orthotics, what they call orthokit, on a patient, and maybe out of a patient bill up to $4,000 or $5,000. And I kind of set up a billing system where most of them were interested in billing for wheelchairs. I was concentrated on billing for these orthokits, and they couldn't figure it out on how to do it. So most of them had to come to me to bill for their provider services. And
was there somebody that gave you this idea initially to participate in this activity, or did somehow you decide you've accessed physician identifier numbers on the computer and figured out how to move forward with this
just
project?
like I heard your last question when you were asking about the knee brace.
Yeah.
I started by understanding the cost of the back brace, which was about $960 against $80. And then, from then I started going into more of it. And then I got to know about the hinged knee braces. All of those things are in the computer. You go online, you can see them and how much they pay for it. And you just get the correct code and bill it. That's all it takes.
Okay. Ms. Zignani and Mr. Sicoccio, have you had an opportunity to read the Affordable Care Act's provisions, the anti-fraud provisions that were enacted in this law? And if so, what's your overall sense of how effective they might be, or what other recommendations would you have that are not included in those provisions that we ought to be looking at making into law to try to really address the fraud and waste and abuse problems that we have?
Yeah, the anti-fraud provisions in the Affordable Care Act, I think, are going to be effective. With respect to the screening, as Dr. Bedetti and Mr. Morris spoke about earlier, screening, the moratorium, bringing in certain classes of providers given the circumstances, the Secretary's ability to suspend payments when there's a credible allegation or credible evidence of fraud. All of those things, I think are good things. The additional resources as far as money that's there, I think also obviously is a good thing, especially given the return on investment that you get. It's unlike maybe some other federal spending. This is money that you put in that you get back a nice return on investment on. As far as other things, I think there's, as CMS goes forward and develops their analytical tools, their data analytics, to the extent that they're able to share that information with private insurers, I think that would be very helpful. In other words, as they say, get into the 21st century with respect to looking at Medicare data, as they begin to find trends and schemes, to be sure to share that with the private side. I mean, we do a lot of that now, but I think it's going to be important as they, because they have probably the largest group of data than any of the other private insurers. Obviously are divided up, by company. Here with Medicare, to be able to get that information that they develop based on those analytics, I think would be very helpful and critical once they're able to do that.
Ms. Ignani, do you agree?
I agree with Mr. Sicoccio. I think further that one could provide more clarity about the sharing of information so that particularly law enforcement agents know that that's permissible. Second, I do believe that there should be more thought to this issue of having safe harbors for health plans that actually provide information to state insurance commissioners, provide information to law enforcement to make sure, to the agency, make sure that that is, it's very clear that that's permissible and there will not be countersuits from providers who are at the other end of that information. And then I do believe that in the area of restitutions, it should be more routine that private sector is included in those restitution agreements and efforts. And then finally, the MLR, sir.
Good. I'll yield back the chair and back to the chairman. Thank you.
Okay, the chair now recognizes the ranking member of the subcommittee, Mr. Lewis.
Thank you very much, Mr. Chairman, and welcome. Thank you for your testimony. We'll have an opportunity to read over. Mr. Oldeligo, we understand that you have been cooperating with law enforcement for over 2 years. Why did you initially get involved with Medicare fraud, and why have you chosen to come forward? What moved you? What suggested to you to cooperate, to come forward?
Before I came forward, I already stopped doing it. I stopped doing that in December of 2007. But I knew there was an ongoing investigation on me. So I approached my attorney right here, and he advised me that the best thing for me to do is come forward and get them to know me and talk to me. And that's how I got to turn myself in. And from then on, I started cooperating with them based on their suggestion.
Do you have any regrets? Would you tell others that may have the desire, the urge to participate in defrauding Medicare or some other federal health program, to tell them,
Yes, sir.
suggest to them that this is not the way to go?
Yeah, I've been doing that already.
Okay. We appreciate that. I'm going to try to get your name right.
Sicoccio. Sicoccio.
Okay, thank you. On your website, you warn consumers about new scam involving healthcare. What are the top scams you have seen to date? What tips do you give consumers?
I think probably if I had to pick the one top scam, it would be identity theft. And that is not just identity theft where person A steals person B's identity in order to get health care, but large-scale identity theft that occurs in Medicare and Medicaid, regrettably on a regular basis, where folks on the inside, that is somebody, say, working at a clinical laboratory or a hospital, decides that they're going to take this information and sell it on the outside, so folks could steal, make false claims. Sometimes the information is obtained through misrepresentations, phone calls where seniors are fooled into turning it, giving their information over the phone. So I think that the biggest one right now is medical identity theft, and the biggest recommendation we give to consumers is to protect your health insurance information, whether it be Medicare, private insurance, whatever it happens to be. Make sure you protect that just like you would a credit card, your Social Security number. Just do not give that information out to anyone on the phone unless you particularly know who you're speaking to. So I think identity theft is really the biggest one. And the other hot areas that we've seen, I think, are similar to Medicare. It's been DME, it's been home health care, it's been infusion therapy, and the other one, community mental health centers are now, I think, becoming a challenge as well. But from a patient and a consumer perspective, I think identity theft is the number one thing they need to look out for.
Thank you. Ms. A. Nini, I understand your members have experience analyzing claims and then using this to predict fraud. Based on their experience, what recommendation or best practice will you share with us and CMS?
I think, sir, that CMS now is in the process of adopting exactly the kinds of tools and techniques that we use. It's called, in statistical terms, predictive modeling, software packages that actually detect anomalies in data. In other words, in a particular area, there are patterns of practice. When you see in the data that a particular physician, a particular pharmacy, a particular area is up significantly, or we've seen situations where physicians are billing over 50-some patients in a day. I mean, that would be an anomaly that this software would flag. We've been very pleased that CMS now and the department is adopting the same kind of tool and technique, and they work very, very well to really give you that early intervention and that kind of emphasis on prevention, so you want to detect fraud before any claim is paid. It's much harder when you're paying and chasing, and it's much better when you can do this earlier on. And that's where we've really focused a great deal of our activities. And frankly, that was the model on which there was a lot of discussion last year, and now the department is actually operating those same skills.
I just want to thank you for being here.
Thank you.
And for your testimony. Mr. Chairman, thank you for holding this hearing.
Thank you. Ms. Jenkins, you may inquire.
Thank you, Mr. Chairman, and I too want to thank you for this hearing, and thank you all for your testimony. Ms. Ignagne, as you are aware, the Medicaid program was designated as high risk by the Government Accountability Office in 2003, and Medicare has been designated that way since 1990. In the last update on these high-risk programs back in February of this year, GAO states that CMS has not met their criteria for having the Medicare program removed from this list, and while they have implemented certain recommendations for Medicaid, more federal oversight of the fiscal and program integrity is needed. The new health reform law expands eligibility to both of these programs. So could you just please address how this will affect your association's ability to reduce fraud over an even larger population and pool of taxpayer dollars?
Well, what our plans have done is actually pioneered a number of different practices which are very, very important. First, credentialing. We've put a lot of resources into making sure that physicians have the qualification that patients expect, that they are licensed, that they don't have malpractice efforts, that they have not been convicted of fraud, et cetera, and just go down the line. Those are very robust activities that we have worked very, very hard to make sure, as we're putting together panels of practitioners and clinicians, that we can guarantee to our beneficiaries that we have executed those processes, number one. Number two, the whole area that the chairman was inquiring about a few minutes ago in terms of how do you step back and prevent fraud, getting the statistical packages operating with, they're called SIUs, Special Investigative Units, with clinicians, with statisticians, with pharmacy experts, with law enforcement experts, so that you can look at what are we seeing in the data, where are their hot spots, if you will, where is there trouble, what needs to be done. We flag claims, and then we do further investigation. So that's on the front end. Also, when payments are made, there are similar processes that are executed to make sure you're following those if we've missed anything, to make sure that we're catching it also on the back end. Similarly for pharmacy, in the area of pharmacy, we have found clinics that are prescribing pain medications. There have been a number of efforts to shut those clinics down, detect them, et cetera. There's been a great deal of work between our health plans and law enforcement and public officials to do exactly that. And you'll see that expanding. Infusion, as Mr. Sicoccio said, we've seen a very, very significant uptick in problems related to infusion. Clinics springing up, billing, and no patients behind those bills. So we've worked very hard to put in place practices that will detect that. Unnecessary procedures that can be life-threatening for patients. We've seen situations where physicians have operated on patients who didn't need those operations, or in some cases people weren't qualified to actually practice the services that they were providing. So unnecessary services, a very, very big area. I must say, of course, that the majority of physicians, of course, are upstanding, ethical individuals, but there are some bad apples, and so our tools and techniques are designed to detect those. We work very closely with Mr. Sicocchio's association that has brought together health plans, law enforcement, public officials to share this kind of information. Mr. Sicocchio does a great deal of training, as he indicated, which is very, very important to make sure that all sides have access to the best practices that work and that work effectively. And now that the public agencies have adopted the practices of private sector plans, then I think there's reason to be very, very hopeful about the ability to do even more to share information under the auspices of Mr. Sicocchio's association and the activities that are underway at the department that we heard about earlier.
Okay, thank you.
Sure.
10 years ago, back in Kansas City, we had one of the most horrendous cases of healthcare fraud that I've ever heard of. A local pharmacist was convicted of diluting nearly 100,000 prescriptions for 4,000 patients. His profits came from diluting expensive chemotherapy medications. A local pharmaceutical sales rep was the first one to suspect foul play. He discovered that pharmacist was selling more of a specific drug than he was purchasing from him. He worked with the doctor who used this pharmacy and the local authorities to bring charges against the pharmacist. Ms. Ignagne and Mr. Sicocchio, you both mentioned the need for more public-private cooperation to help combat healthcare fraud. The case I just mentioned was greatly assisted by private companies. Can either one of you elaborate on what else those of us in Congress can do to allow and encourage private companies to work with CMS and our law enforcement to reduce fraud in the system?
Well, I think, as I mentioned, data analysis is going to become critical going forward. CMS is in the process of looking for and putting in place the right type of system as far as predictive modeling for Medicare. I think it's going to be critically important as they develop these systems on the set of data that they have, which is an enormous set of data, that data be shared, that what comes out of that data be shared with the private side. It's critically important, not just for the commercial side, but remember, again, the private insurers have Medicare Part C, Part D. They're doing Medicaid in the state, so there's a lot of tie-in both between the private side and the public side in the public program. So I think that sharing of data is going to be critically important. And then I think the other thing is there's a commitment, I believe, on the part of the IG and HHS, CMS, and DOJ to share information with the private side. I think a lot of that information has to filter down to the agents in the field, that they need very specific guidance about what they can and can't do. And we've been working with Mr. Morris, with Dr. Bedetti and others to try to address that particular issue, and hopefully in the near future we're going to see some progress along those lines to where agents in the field know, okay, this is not only okay for me to do, it's something that I should be doing.
Thank you. We'll look forward to working with you. I yield back.
One final question for you, Mr. Odeluga. How easy is it to get physician provider numbers in your experience, and to file additional claims, depending, if you get denied, getting a different number and filing additional claims? Can you talk a little more about your experience with that?
Thank you, Mr. Chairman. Basically, to get a physician's UPI number, you just have to go online and pick it up. It's public information.
So just go online, you can find these numbers and...
You just get it from there. You can even get the one that has a closer zip code to wherever the patient lives, and you can input it on the system and transmit.
Is there a method to what provider numbers you would pinpoint? Do you look for those who perhaps may be licensed in multiple states versus just in a single location?
Well, as most providers will want to get licensed in every 4 regions of Medicare.
Okay.
That way, they can bill for any patient depending on where they are.
Yeah.
That's why if you look at my statement or my recommendations here, I was trying to suggest a way where any claim that doesn't cross-reference with the doctor's billing for the services should not be paid. That way, providers cannot just turn in any claim without the doctor billing for the services of recommending, doing the prescription.
Okay.
They should try to implement a way where, because most of these are done by the billers. The billers know whatever is going on between the doctors and the providers, but they transmit the claim. If they can have a way where they can get the billers to be held responsible a little bit of whatever that's going on, it can help the system.
Thank you. Mr. Lewis, do you have any further questions?
Mr. Chairman, I don't have any further questions.
Thank you. Well, that will conclude our questioning of the witnesses. I want to thank all of you for being here today and providing your testimony and answering questions of the members. I want to remind you that members may have some written questions they would like to submit later to you, and ask you if you would oblige and make those answers part of the record. One final thing, Mr. Ranking Member, Mr. Roscom, a full member of the committee, has a statement he would like to submit for the record without objection.
Without objection.
Without objection, so ordered. And with that, we will conclude this hearing, and the hearing is adjourned. Thank you.
Thank you.